We have another great program today. Next is Dr. Allison Weber from the University of California in San Francisco. Dr. Weber is a transplant nephrologist and will introduce and outline the kidney transplant program at UCSF. And with Dr. Weber are 3 members of the UCSF transplant team who will participate in the question and answer session following Dr. Weber's presentation. And they are Linda Murkowski, right over here, who is a nurse and transplant coordinator, Deb Tiji, also a nurse and transplant coordinator, and Martha Relis, the kidney and pancreas transplant manager. So we're thrilled that they are all here to join us today. UCSF has performed more kidney transplantations than any other hospital in the world. Its kidney team evaluates about 1,200 patients a year as potential transplant candidates. Currently, UCSF performs more than 300 kidney transplants each year, twice as many as any transplantation program in Northern California. Well, now it's my pleasure to introduce our distinguished presenter. Dr. Allison Weber is Assistant Clinical Professor of Transplant Nephrology at the University of California, San Francisco. Dr. Weber received her Bachelor of Arts degree, magna cum laude, in English. Who says that English majors cannot get a job? From the University of Pennsylvania, and her medical degree from Albert Einstein College of Medicine in New York. After graduation, Dr. Weber performed her internship and residency at New York Presbyterian Hospital, Cornell Medical Center, and served as chief medical resident at the New York Downtown New York Presbyterian Hospital. Thereafter, Dr. Weber completed 2 fellowships, first in nephrology, then in transplantation medicine at Cornell Medical Center. She is board certified in both internal medicine and nephrology. Dr. Weber is a recipient of numerous honors and awards. The Alpha Omega Alpha Honor Medical Society at Albert Einstein College in 2002, the American Medical Women's Association Janet M. Glasgow Achievement Citation in 2002, the A. Lee Winston, MD Senior Resident Teaching Award for Excellence in Clinical Care, Compassion, and Humanitarianism at Cornell Medical Center in 2005, the Distinguished House Staff Award for All-Around Excellence, Cornell Medical Center in 2007, and others. Dr. Weber has conducted extensive research and has been published in numerous medical journals, including Transplantation, Kidney International, and Blood. She is a member of the American Society of Transplantation, the American Society of Nephrology, the International Society of Nephrology, and the Alpha Omega Alpha Society, to mention just a few. Dr. Weber has asked you to reserve your questions for after her presentation, and there will be generous time for the Q&A at that time. So please give a warm welcome to Dr. Allison Weber.
Thank you very much. I'm very honored to be here today to talk to you about kidney transplantation and at UCSF Medical Center and our transplantation program. So thank you so much for the invitation. So I'm first going to talk about our personnel at UCSF. Who are the people that you're likely to meet? Who will be your caretakers when you join us at UCSF? Nancy Asher is the chairman of the entire surgical department at UCSF and is a transplant surgeon herself. John Roberts, who is the division chief of transplantation surgery, is with us as well. And we have a total of 8 surgeons, as you can see, all who are specialists in kidney transplantation, pancreas transplantation, liver transplantation as well. There are 5 transplant nephrologists at UCSF. Brian Lee, Steve Tomanovich, Flavia Vincenti, myself, and David Wojciechowski. But as you know, transplantation, the Department of Transplantation requires multiple people to make it happen, including our nurse coordinators, our transplant coordinators, which are really the backbone of the transplant department. Martha Rellis is here today. She is our kidney and pancreas manager. We have many nurse coordinators, two of which are here today as well, Linda Muskowski and Deb Tichy. So we're very happy to have them here today. In the post-transplant side, we have two full-time nurse practitioners, Melanie Makarick and Sue Robertson, and Nancy Fong Hum is the inpatient nurse coordinator. We have social workers and we have financial counselors. So it's really a large department with a huge team of nurses, coordinators, social workers, financial counselors, all ready and able to assist you through the transplant process. So I'm going to give a little brief overview of what one can expect on a pre-transplant evaluation. As mentioned, we do 1,200 evaluations a year. These are patients who are coming to see us to list themselves for kidney transplantation, and they get evaluated by multiple people from all different disciplines, including a transplant doctor. Either a surgeon or a nephrologist will be evaluating, doing a medical history, physical examination, the nurse coordinator, a social worker, financial counselor, and a dietitian. So there'll be multiple people that you'll be meeting with on the day of your evaluation. And you'll have blood drawn on that day. And the blood drawn is going to be for your blood type, A, B, or O, HLA type, and I'll be going into more details about what does that mean, what is an HLA type. Anti-HLA type, again, I'll be going into more details on what does that mean exactly, as well as looking for viruses. That sounds a little scary, but everybody, 80% to 90% of the population has been exposed to different types of viruses, which can become problematic for patients on immunosuppression. And so we screen all patients on that day for these types of viruses. So what can you expect after your visit? You can expect 2 letters approximately 4 weeks after your visit. 1 is a generic listing letter, and 2 is a plan of care letter, indicating what your blood type is and possible further testing needed that you'll be completing through your local MD. So your medical evaluation will go through your medical history in a very thorough way, and will decide what further tests do we need from you prior to feeling comfortable that you are ready for kidney transplantation. Your list date will be given to you as well, and your activation date if you meet the criteria for activation. And you'll also be assigned a coordinator. For patients who have living donors, your case will be forwarded to a living donor coordinator once the donor has filled out their questionnaire. So let's talk about the history of UCSF Transplant Service. Began in 1963. We've performed over 9,000 kidney transplants. And I'm very proud to be associated with UCSF. It's been a real long-time leader in innovative ideas to improve transplantation. Huge amounts of research has been done, both in helping to monitor kidney transplant patients, as well as to come up with new ideas for immunosuppressive regimens at our institution. So what are some options for kidney failure treatment? You know, unlike liver failure patients, heart failure patients, there are options other than transplantation. Those options, you're well aware of them, are hemodialysis, peritoneal dialysis, and then kidney transplantation. And the best treatment for you depends on your medical history, your health status, and your personal situation. There are other options besides kidney transplantation, which, as mentioned, you know, is not the same thing for other types of organ failure. What are some of the benefits of transplantation? Well, there has been multiple studies that have shown with the correct candidates that it increases lifespan, improves quality of life, and certainly there's a higher frequency of rehabilitation associated with transplantation. So let's go through the basics of the types of kidney transplants. There are living donor transplants. This can be a living related donor, a parent, a child, or a sibling, or a living unrelated donor, a spouse, a friend, a colleague. And then there's deceased or cadaveric donors. And these are donors that have suffered from brain death, and their family has volunteered the person's kidney to help others. So these are our statistics from UCSF from 2007 through 2010. We've done 206, in 2010 we performed 206 cadaveric kidney transplants. We've performed 141 living donor kidney transplants. And we performed 18 simultaneous pancreas kidney transplants. And those are for patients with type 1 diabetes, also known as juvenile diabetes, who benefit from a simultaneous pancreas and kidney transplant. So what are some requirements for organ transplantation? You need a compatible blood type. It doesn't have to be a perfect blood type, perfectly matched, but it has to be compatible. So what are some basics? What does that mean? So again, as mentioned, there's type A, type B, type AB, and type O. So clearly an A can give to an A, and a B can donate to a B. An O is called the universal donor. An O can donate to anybody. They can donate to an A, to an AB, and to a B and an O. An AB, type AB, is called the universal recipient. They can receive from any donor. So if you are a type AB, that means any blood type, from any person will be okay for you. You can get a kidney from that person. The other thing that's required is, and you hear a lot about matching, oh, it's a perfect match, it's a 2 out of 6 match, it's a 3 out of 6 match. Our immunosuppressive medications are so excellent these days that the reason why you can get a transplant from an unrelated person is because the matching doesn't matter so much. If you have a living donor who is compatible with a blood type, they don't have to be a perfect match. 1 out of 6 matches is almost as good, if not just as good, as 6 out of 6 matches. But what you can't have is you can't have a positive cross match. And that's when you do a mixing of the donor blood and recipient blood. That's called a cross match. So what does that mean? What is a cross match? Cross match means, a positive cross match means that at some point in your life, if you have received a blood transfusion, if you have been pregnant, clearly in the case of women, if you've had a prior transplantation, that your body has seen foreign material before. Your body has seen someone else's blood. Your body has seen someone else's kidney. Or your body has seen a fetus that is half not yours. You may have developed in that setting an immune response where your body has developed cells or antibodies to the proteins that were in that blood or on that kidney, and you may then therefore have antibodies to a potential donor for you. So if we mix your blood and we mix it with the donor blood, we might see a reaction that says, oh, I've seen that protein before. I have cells against that protein before, and that's a positive cross match. And that we cannot transplant that kidney for you. That's not going to be the right kidney for you. What else do you need for organ transplantation? You need no current medical problems that would prevent the transplant surgery. Transplant surgery is a big surgery, and if you're having active medical issues, it's probably not the right time for you to undergo a major surgery. And importantly, your candidacy for transplant can change at any time. Things happen, we live our lives, and that's why we are eager to be updated with your medical history as you're on the list. I'm going to go back over the immune system again. So what is your immune system? Your immune system protects you from foreign invaders, and your body will consider the new kidney a foreign invader. And that's what rejection means. So you have an immune system. These are white blood cells. These are antibodies. These are the cells and the antibodies that are responsible for fighting off infections. They can recognize a virus, they can recognize a bacteria, and they can fight off that infection. These are the same cells that are going to recognize that kidney as not belonging to you. And they're going to try to attack that kidney. And that's what rejection is of a kidney. So we put you on multiple medications called immunosuppressive medications to suppress your immune system to keep the kidney from being rejected or from being attacked. Your body will never forget that the kidney is from somebody else. So 10 years go by, you've got a kidney transplant, you're doing beautifully. Can't decide on that day, you know what, these medications, I don't like them anymore, I'm going to stop taking them. Your immune system will always remember that that kidney is not yours and will wake up and attack and potentially reject the kidney. So the medicine has to be taken the duration of the kidney transplant. So let's go back over HLA or tissue typing. So what is HLA is what we look at for matching, as I mentioned before. And as I mentioned before, it doesn't matter how well you are matched. It only matters that you have not developed an immune reaction in the past to these same molecules that have been your body has seen before. So HLA or tissue typing, these are molecules on the cell surfaces that identify you from somebody else. Anti-HLA antibodies are what we look for and what will cause a positive cross-match, which makes that donor not the right donor for you. And these anti-HLA antibodies develop in response to exposure to foreign proteins. So again, how do you get exposed to foreign proteins? Through blood transfusions, through pregnancy, through prior transplants, and through infections. All right, let's go over the anatomy. So this is, these are your kidneys. These are the diseased kidneys. In most kidney diseases, they tend to shrink over time, become what we call atrophic. They're not being used, they're not functioning appropriately, and so therefore they shrink down and become very small. And so that's what it's saying is the diseased kidney. Under certain diseases, however, polycystic kidney disease is one example, they actually are not small, they are very large. But for the most part, end-stage kidney disease patients have small kidneys. So what happens with a kidney transplant? Where does the transplant go? Firstly, we do not remove the old kidneys when we do a kidney transplant. This is something that seems to always surprise people. With other transplantations, like liver transplantations, you remove the damaged, diseased organ. Kidney transplantation, we do not need to remove the kidneys, and we don't unless there is a clear medical indication for removing the kidneys. Again, in the case of polycystic kidney disease, sometimes these large kidneys become very problematic. They cause chronic pain, infections, and stones. We may remove them under, with each individual being evaluated separately under those circumstances. But we hook the kidney up to the front. So your native kidneys are in the back. The transplant kidney gets hooked up into the front, right in the front. It gets attached with, it has a renal artery and a renal vein. So every organ needs to have an artery and a vein to get supplied with fresh oxygen. So the renal artery and renal vein get hooked up to the iliac artery and the iliac vein. Right there. Those are the same arteries and veins that supply the legs with blood supply. That means that if someone has significant peripheral vascular disease, where they have a lot of atherosclerosis, cholesterol, plaque in the lower extremities, it may be very difficult to hook up the kidney to those blood vessels because it could compromise the blood flow to the lower extremities. So that's something that we often look at very carefully in our patients to make sure how is the blood flow to their legs. Would it be a safe anastomosis hookup to the blood vessels to the legs? And then the ureter, which is what brings the urine that's made by the kidney into the bladder, gets hooked up to the bladder. Again, we do not remove the old kidneys. So what about the hospital stay after a kidney transplant? The transplant usually occurs in the first hospital day, and the surgery is about 3 to 4 hours. We have a specialized nursing unit over at UCSF, 9 Long, where it is a transplant floor. The nurses are trained in transplant. You'll see there are kidney transplant patients, pancreas transplant patients there, and liver transplant patients on this floor. And as mentioned, all the nurses are specialists in transplantation. The hospital stay can last anywhere from 3 to 10 days, but 3 days is it's not incorrect. 3 days is correct. Oftentimes, we will be able to discharge the patient, the donor, within 3 days. We like to get our patients out of bed immediately. We want them walking around. We want them to do a certain amount of laps right after a kidney transplantation. We don't want them lying in bed because that's when complications can happen. You begin to take your medications, your immunosuppressive medications, these are the anti-rejection medications, immediately on the first day of your transplantation. Because like I said, your immune system is there, it's ready to attack what it's seeing as not belonging to itself, and so we need to get those medications on board immediately. And then the discharge, of course, depends on how you're doing, how your kidney is doing. Is it functioning well? Do you understand all your new medications? Are you comfortable? Is your pain well controlled? And clearly, as you may understand, this is not just a simple surgery. This is not taking out someone's gallbladder. This is putting in an organ, and this comes with immunosuppressive medications. It comes with a whole change in your physiology. Someone who goes from having no kidney function all of a sudden has perfect kidney function. These are the electrolytes are maybe all different before and after transplantation. Blood pressure may be completely different before and after transplantation. So these are all brand new things that are going to be happening to your body after a kidney transplant that we clearly need to make sure you're doing well. So what are some surgical complications that can happen? Well, some of the surgical complications after a kidney transplant are the same kind of complications that happen after any type of surgery. Bleeding problems that can happen after any kind of surgery. Wound healing, clearly an appendectomy, a cholecystectomy, these are all, you can always have wound healing problems. And then there are some complications that are specific to urologic or kidney surgeries. One is called a urine leak. What's a urine leak? Some kind of the integrity of the anastomosis, so the sewing of the ureter to the bladder has been, there's an issue with the anastomosis, and urine leaks out into the abdomen. Doesn't sound like that's any fun, but we certainly monitor for that afterwards, and it's easy to repair. Urine obstruction, this is if there's some kind of obstruction of the tubing. So the kidney drains into the ureter drains into the bladder. If there's some kind of collection or something that's blocking the drainage of that urine into the bladder, that's a urine obstruction. And then lymphostele is a collection of lymph that is, when they go in and they do their incisions, sometimes they can cut a couple of lymphatics, and that can cause a little lymph leak. It's not anything that's serious, and we see this quite frequently, actually. But then there's a whole medical side of this. This is why every patient in our hospital is followed by both a surgeon for the surgery, clearly, and then any kind of complications that are surgical complications. But there's a whole medical list of things that can happen after transplantation. We already talked about rejection. If we're not adequately immunosuppressing you, your body will wake up and see that kidney is not belonging to you and start to attack it. And we'll see that because your creatinine will start to go up, and we'll know that something's going on. Infections. So you're going to be taking medications that are suppressing that immune system. Those white blood cells and those antibodies that are there to fight infections are the same cells that are going to attack the kidney. So we suppress those cells with our medications. That leaves our transplant patients more susceptible to infections than other patients. These patients are immunocompromised patients. And so as mentioned, they can get more bacterial infections, certain infections that everybody can get, they'll get, and then certain infections that patients who are immunocompetent or who are not on immunosuppressive medications actually do not get. Transplant patients do get. High blood pressure. Blood pressure fluctuates very dramatically after transplantation. Patients who go in sometimes with very high blood pressure, which we see frequently in our dialysis patients, may develop low blood pressure after kidney transplant. Patients who have diabetes as the cause of their kidney failure, some of our medications that we give actually can make diabetes a little bit worse. And so the regimens for the regimen for diabetes, the insulin requirements, may go up after transplantation. Also because some people may have had diabetes and they go on dialysis, and all of a sudden their sugars are low on dialysis. Well, now that's because some of the insulin is cleared by a kidney, so that when you don't have kidney function, your insulin is hanging out in your body for a lot longer. Well, then all of a sudden we give you a kidney, and now it's cleared, and so you may require insulin again after transplantation. Cholesterol is a problem even before and after transplantation. Certain cancers are more likely to develop in a transplant patient. The most common cancer that we see are skin cancers, not melanomas, mainly basal cells and squamous cell carcinomas. So we encourage all of our transplant patients to stay out of the sun as much as possible, wear sunscreen, and get a yearly dermatologic evaluation. And then what about the reappearance of the original kidney disease? Well, certain diseases can come back in the transplanted kidney. One is diabetes. If you've lost your native kidneys from diabetes, if your sugars are poorly controlled, the diabetes may reoccur in the transplanted kidney. Certain primary kidney diseases like IgA nephropathy, FSGS, some of the primary glomerular nephritides, they can recur in the kidney transplant. And so we watch for those things very carefully. So those are things that you need to know, and that's why a transplant nephrologist follows you very carefully. So the anti-rejection or immunosuppressive medications, there's several of them, and which combination of medications is going to be individualized. And it's going to be prescribed based on your cause of your kidney disease, your medical history, and other medications that you are taking. And that's how we're going to decide what's the best regimen for you. If you're high risk for rejection, we might choose one set. If you have diabetes and your sugars are not well controlled, we might avoid one of our medications that can make it even worse. So every person gets evaluated individually, and the particular regimen of immunosuppressive medications is individualized. And again, just to reiterate, these medications have to be taken for as long as you have the kidney transplant. What are some other medications besides the immunosuppressive medications that you're going to be taking? Well, for 3 to 6 months after kidney transplant, we prophylax against certain infections that we think are common in kidney transplant patients. So most patients will leave the hospital on both the immunosuppressive medications and prophylactic antibiotics, antifungals, and antiviral agents. These get peeled off one by one as you get further away from transplant, because the risk of those infections is really the highest early on after transplant, because that's when you're the most highly immunosuppressed. So these are not lifelong medications like the rejection medications are. Patients are discharged home on ulcer medications, and then of course medications needed for other illnesses including high blood pressure and diabetes.